from that point. Okay, good morning. We are having a ward round scenario discussion today on management of chest injury. Dr. Aditi Singh, who is a second year junior resident at Howrah District Hospital, will present, and Professor Prashanta Kumar Bhattacharya, who is professor and head of surgery at College of Medicine, Sagarotta Hospital at Kamarhati, will moderate the session today. So Aditi, you share the screen and read the first two paragraphs.
Sir, a 22-year-old man was involved in a high-speed head-on automobile collision. When he arrived in ED, he was cold and diaphoretic, and his BP was 110 by 80 mmHg. He had regular pulse rate of 110 per minute, respiratory rate 30 breaths per minute, and GCS 14. His voice was normal. Chest wall was tender with extensive subcutaneous emphysema. Breath sounds on the left was diminished. Neck veins were not engorged and heart sounds were normal. Secondary survey.
No, don't go to that. Just stop. Let Professor Bhattacharya ask you how do you proceed from this point. These are the primary history taken by somebody, and just a preliminary few findings. Then let Dr. Bhattacharya ask you how do you proceed. Don't read the remaining part. We'll go step by step.
Okay. Good morning, Aditi.
Good morning, sir.
Good morning. Now, you said that his voice was normal. What does that signify?
So that airway injury is patient is airway is intact.
Good.
Patent, you mean? There's no obstruction.
No airway obstruction.
Okay. Now, you what are the things you should look for when you examine a patient of, say, blunt injury, blunt trauma chest? What are the things you look for in the chest examination or thoracic examination?
Dr. Bhattacharya, I think she would answer is a high-speed collision. This patient is brought to ER. So before you pass on to the chest, GCS is 14. So there is some component of neural component. So what should be the optimal steps for managing such a patient before you go to the chest?
Sir, first we will do the primary survey of the patient.
Primary survey is part of one protocol. Just start like that. It sounds good. If you say, sir, this is a road traffic accident, I will follow ATLS protocol for managing this patient. And then start. What does the ATLS protocol comprises of?
Sir, we'll do the ABC airway examination.
Again, you see, the ATLS protocol has three main components. One is primary survey and resuscitation, secondary survey, and the definitive management. So ATLS protocol is the three broad steps. So once you come to the primary survey and resuscitation, then the ABCDE come. Got my point? So be methodical in answering a trauma. Say trauma will be head trauma, abdominal trauma, chest trauma. So last day we discussed about the abdominal trauma. Probably you're not there. So we have discussed this part. We'll not go into the depth of all this because last class we have discussed about how to maintain airway, breathing. So, but think of the basic steps. So you will follow the ATLS protocol, primary survey resolution, secondary survey, and the definitive management. Primary survey will comprise what? In brief?
Airway, we will check for the airway, breathing and ventilation, circulation.
This ATLS protocol is very strict. If you say only airway, that's not enough. Airway with
cervical spine injury.
No, not injury. Cervical spine control.
Okay.
When you maintain airway, cervical spine control is one important part of airway. You cannot turn the neck on this side, that side, or extend the neck forcibly. Okay, so A. Next is B.
So B, we'll check for breathing and ventilation of the patient.
Yes.
Then circulation, and if there is any hemorrhage, ongoing hemorrhage, disability, if there is any, and then exposure.
D is what?
So disability, if there is any disability, we will check for the GCS of the patient.
No, try to understand. In ATLS protocol, it is not GCS. This D stands for primary neural assessment. That goes by AVPU. Got it? It's not GCS full in this step. GCS will come little later. When you go for primary survey, it is AVPU. Whether the patient is alert, that means he's responding to your calls. He is not alert. You ask him a question, he is responding. So he is voice responsive. You ask some question, he is not responding. Give some painful stimulus, he is responding. That is P. If you give painful stimulus, not responding, it is U. That indicates severity of neural deficit. Okay, that is AVPU, not GCS. In D, it is AVPU. Okay, now the primary survey is done. And this is the finding on some of this point. And now get on to the doctor's Bhattacharya question. So the patient has got a suspected chest injury.
Yeah. Suspect. Hello, Aditi. Aditi, I think she's,
Oh,
the link is lost, I think.
just wait for 1 or 2 minutes. This happens. No, she's logged out. We are putting one class in one. Let the patient have one more. Okay? Then Razik hai na?
She's online again.
Yeah, Aditi.
Sir,
Yeah, yeah. But
connection.
listen to Dr. Bhattacharya's
Yes.
question.
Yeah. So I asked you what are the things you should look for during the chest examination, thoracic examination. You have
Sir,
exposed the
during
patient.
thoracic,
Continue.
sir, we'll look for any if there is any bruising or on the chest wall. If patient
Yeah,
is
divided
in
into
respiratory
inspection,
distress.
divided into inspection, palpation, percussion, and auscultation. 4 broad headings.
Yes, sir.
Tell us.
Yes, sir. So first we'll do the inspection part. We'll look for any if there is any bruising, if the patient has any respiratory distress.
Okay.
Then sir, we'll note the depth of the patient, respiratory depth of the patient.
Yes,
If there
respiratory
is
rate and
if there
depth.
is proper chest expansion.
Very good.
Then
Next.
if there is any symmetry of the chest wall,
Yeah,
then
very
movement of the chest wall.
Whether the movement of the chest wall is symmetrical or asymmetrical. Okay. Both
Asymmetrical,
sides is
yes.
expanding equally or not. And
Yes, sir. So then
at the same time, you
then
should
we'll
look
do
for whether there is any distended neck veins or not. Okay.
yes, sir. Yes, sir.
Distended. Then comes palpation. What are the things you should look for?
Before palpation, Aditi, when you talk of chest
Yes, sir.
movement, when you talk of chest
Yes, sir.
movement, what do you mean
Yes,
by
sir.
paradoxical movement in the chest wall? Paradoxical movement in the chest wall.
So paradoxical movement means
What happens in normal respiration? During inspiration, chest.
so during normally chest wall moves with
Outward. Chest expands during inspiration.
outward. Yes, sir.
Expiration, chest
But in paradoxical,
recoils. What happens in paradoxical respiration?
in paradoxical, during inspiration, chest wall is moves inward.
Inward,
No, not
yes.
chest wall. That is a frail segment. Usually,
Yes. A segment of chest
respiration-
move inward. A
Yeah, that is
segment
a
of
frail
chest move
segment will
inward.
move inward.
That is
Rest of
important.
the chest will move
That is
out.
important. Why?
So that
If you
will
find
be
that
due to
yes, a
flare
segment
chest.
of chest is showing this paradoxical movement, what's in your mind?
So flare segment or multiple rib fracture.
Yes. So that
Yes.
when you talk of chest movement, apart from this symmetrical movement, acid movement, you also should look for any paradoxical movement in the chest wall. Okay, that is important.
Yes, sir.
And also you should Okay, come on, go to the palpation. What is first thing in
Uh,
palpation?
So, on palpation, we palpate for symmetrical or asymmetrical chest
Before that,
expansion.
before
And
that, another important finding in palpation, which will suggest there is a gross mediastinal shift or not. What is
Go
that palpation?
above to the sternal notch.
If the patient
Sorry,
has
sir?
got a chest injury on one side with a hemothorax, pneumothorax, whatever, there will be some
Yes.
changes in the trachea and the apex beat.
So tracheal deviation will be there.
Yes, whether the trachea is at the
Apex
central
beat.
part or there is deviation of the trachea. Next, go to the expansion. If there is any, as you said, this patient had some subcutaneous emphysema. Okay,
Yes, sir.
and any obvious crepitus because of movement of the fragmented ribs. Okay, during
Yes,
chest,
sir.
when you are examining for the chest wall expansion, you feel whether you can feel the broken segment of the ribs as well that moving. All right.
Yes, sir.
Next,
So
percussion.
we'll check for, sir, apex
Percussion.
beat.
Percussion.
So on percussion, we'll look for the dull or resonance. If we are finding
Yeah.
dull
Percussion
or,
note, whether it is dull or resonant or hyper
resonant.
resonant, that you have to see. Okay.
Yes, sir.
Next,
Yes.
auscultation.
Then auscultation, we'll check, sir, breath sounds, normal breath sounds.
Yes.
Any added sound.
Mhm. Whether the breath sounds are audible or not, that
The
or they are
hereditary
rigid.
is,
Yeah.
yes. If the hereditary is equal or not.
Yes. And what else?
And
You just mentioned about the apex beat or something. So on auscultation, you should.
where we can hear the apex beat, sir, if it's displaced, then there is then we can suspect injury.
No, it's not displacement. Whether the heart sounds are normally audible or the
Yes.
heart sounds
Yes.
appears to be muffled. What does
What
that
is big
indicate?
striate? What is big striate? That is important for chest injury. Big striate.
Found in pericardial tamponade, cardiac tamponade. What is that?
Jugular venous distension, heart
Yes.
sound muffled, and hypotension.
Very good. Very good.
And
Very good.
and if you consider these big striate is present, what else maybe they are in pulse? If the patient has got a cardiac tamponade? What do you call
Sir,
it?
What
Big
type of
striate.
pulse?
Hypotension, increased JBP and muffled heart sound. This is big striate. Apart from this,
Yes, sir.
patient may have what change in the pulse?
A particular type of pulse.
Usually pulses.
Pulses paradoxes.
Yes.
Very
So
good.
that
What
is
is
very
that?
important. You see, while you are examining the chest, the cardiac
Yes.
injury is also part of the chest injury.
All right. Okay, are you there still? You are lost.
Sir?
Hello. Yeah. Okay.
Yes,
Now
sir.
that you have examined the chest, what are the things? How should you approach this patient now? Well, like you have done the primary survey, examine
Yes.
the chest proper. What are the other things that you should look for very rapidly? That will go into the secondary survey.
Yes, sir. Sir, we'll look for a secondary survey in, we'll look for any abdominal tenderness. If the patient has the stable.
There is another question at this point. In
Yes, sir.
ATLS, we do primary survey and then go to secondary survey. But in between,
Yes.
there are some injuries which need to
Yes.
be addressed immediately before you go to secondary.
Yes,
So
sir.
otherwise, the patient will die. You cannot send the
Yes, sir.
patient to some department for X-ray or something when the patient has got
Yes,
these
sir.
conditions. What are the three conditions? What you should address before you address
So
for the secondary survey and send the patient to somewhere else for some investigation? What are the life-threatening injuries?
Sir, ongoing hemorrhage,
Where?
chest.
That means a massive hemothorax. That is one. Second, You have not heard of something called tension pneumothorax
Not Hamlet, sir.
and cardiac tamponade. If these
Cardiac
three
tamponade.
injuries are there, and
Yes, sir.
you cannot go for secondary survey unless you address these three prime injuries, because patient will die.
Okay.
So how do you address these three issues before you go for secondary survey? Patient has got tension pneumothorax, severe
Yes, sir.
respiratory distress, cyanosis, mediastinal sheath, hypotension.
Yes, sir. So
What do you do?
We'll do the intercostal chest tube drill first before doing the secondary survey.
Chest tube drainage is not available. You are in emergency.
If you're,
Sister cannot give you the chest tube.
Sir,
How can you relieve? Got my point?
patient
in
is having
ER.
tension
Yes.
pneumothorax with severe respiratory distress,
yes,
must
sir.
be relieved immediately.
Yes, sir.
How can you do
Sir,
that?
endotracheal tube.
No.
You can
It
just
will
simply
aggravate
put a
the
needle.
tension pneumothorax. If you put endotracheal tube and start ventilating, patient will deteriorate. The next is
Put a
India
needle,
heard of
wide
needle
bone needle.
thoracotomy. He did not heard of a term called needle thoracotomy. That is an immediate life-saving
Yes.
measure. You are not
Yes, sir.
putting a chest tube takes some time. You need the logistics. But if you feel the
Yes.
patient is almost cyanosed, patient is severe hypotensive, you can just insert a wide bone needle in the second intercostal space.
Yes,
That's the
sir.
stana. Okay, so that can
Yes.
buy you some time. You're right. The final part is you have to put a chest tube. Then, how do you relieve cardiac tamponade? Patient has massive cardiac tamponade, muffled heart sound, GBP high, severe hypotension.
Sir.
Simple.
Same.
That is
Okay.
needle pericardiocentesis.
Needle
Put a needle in chest
Yes.
for tension pneumothorax. Put a needle into the peritoneal cavity for relieving the tamponade. Okay.
Yes, sir.
Where is this needle placed, Aditi? For pericardial tamponade relief, where do you place this needle? It is at
Sir,
the region of
left fifth
Ziphisternal
intercostal
junction.
space.
Ziphisternal junction pointing the needle towards the opposite on the left shoulder. Is a Ziphisternal junction pointing the needle towards the left shoulder. That is the direction for putting needle in the pericardial cavity. Okay, so keep in mind that once you answer the primary survey, secondary survey, at the end of primary
Yes.
survey, you have to say that I need to exclude some life-threatening injuries before I pass on to secondary survey. Okay, so address these three
Yes, sir,
issues.
yes.
If it is traumatic hemothorax, needle will not work. If a massive hemothorax with hypotension, mediastinal sheath, you have to put a chest tube before you proceed further. Okay, now pass on to secondary survey. Yes, this is a patient who does not have massive chest injury, but there is some chest injury with history of high impact collision. What in secondary survey?
So we'll do the tip to toe examination after the primary survey and resuscitation of the patient. And we'll take detailed history of the patient if there is any allergy, if the patient is on any
Before allergy,
medication.
we have not
No.
taken the history. We have not even
Yes.
taken the history of the mechanism of injury, what happened immediately after the injury, somebody else
Yes,
has died
sir.
on the spot or not. So these are all important
Yes.
part of history. Secondary survey starts with history,
Yes.
and then an examination
Yes.
from head to foot, and then you plan your definitive management. Got my point? If you have a life-threatening
Yes.
injury, you address that. And secondary survey will include the history of accident, what happened between the time of accident until arrival to the hospital. And
Yes.
then in the hospital, you take history to exclude injury of different systems. There are specific symptoms which will suggest
Yes, sir.
chest injury may also be the liver injury, may also be the splenic injury. So there are a lot of symptoms that will come up. So go with that chronology. Aditi, secondary survey starts with
Sir, tertiary survey after stabilizing the patient.
secondary,
No.
not tertiary survey. Secondary
Secondary.
survey starts with what? Secondary
Sorry, sir?
survey starts with the history of what?
History of different systems
No,
of the body, like
No, no, no.
abdominal.
Mechanism
No.
of
You are given a high collision injury. So who was this man? Was he driving the car? He has got a seatbelt injury.
Mechanism
He
of
was in the
injury.
back of the seat.
yeah.
So if you have 3-4 occupants, if you find a history that one fellow has died on the spot, what does it indicate? He was riding with another
Patient-
person and that person has died on the spot.
High risk. So
That indicates a very
that means
severe violence. Got my point?
high risk.
If somebody
Yes,
else
sir.
in the car has died on the spot and this man has come to you, that indicates that is a very severe impact.
Yes, sir.
And then now you have some standby people who has brought the patient. If the patient is conscious, he can give the history, go chronologically
Yes.
to the history. Start with the head. What symptom he may have if he has got a head injury.
Even the the degree of damage that the car sustained, that is also important.
Yes, yes.
Understood? Whether the
Mangle car,
Yeah.
car.
airbags were deployed or not, and these will indicate the degree of the trauma or injury, the velocity of injury.
Yes, sir. So we'll start with head. We'll look for any scalp injury if there is any facial deformity or prominence. Then
Any-
eyes.
Can you ask some
No.
symptoms which will suggest underlying head injury? Some symptoms which will suggest a underlying injury in
So
the brain.
yes, so we'll ask for the history of if the patient has episode of vomiting or
What are
loss
the
of
symptoms of
consciousness.
increased ICT? Symptoms of increased intracranial tension, which will suggest there is some hemorrhage in the intracranial cavity. Symptoms are headache,
So
Headache.
convulsion, vomiting,
headache, vomiting,
loss of
history of loss of.
consciousness.
You have not talked of his history of loss of. He is now conscious. If the people who have brought her say that patient was unconscious for some time at the time of accident, that is very important.
Yes, sir.
Patient may be
Yes,
lucid
sir.
interval.
Yes, sir.
So take a proper history. You see, chest injury does not mean only the chest part. It's a general approach. Maybe that your exam will finish up before you go to the chest injury. These are the primary management. So to diagnose underlying intracranial hematomas, you ask some symptoms which will suggest increased intracranial tension, headache, vomiting, loss of consciousness, convulsion, any focal neurological deficit. Patient can say that I cannot move my right upper lip, or I cannot move the whole of my right side of the body, which might indicate some
Yes, sir.
compressive hematoma on the opposite side.
Yes, sir.
Any speech problem. Okay. And then patient may
Yes.
have some symptoms of cranial nerve palsy. You got my point. Patient, depending on the underlying hemorrhage, there may be compression of the particular cranial nerve. The patient may have a squint.
Yes, sir.
So these are the history about head injury. Then come to the face, as you are talking of. Any bleeding from the
Yes,
ear,
sir.
nose, any blackening of the eyes.
Yes, a blackening or periorbital ecchymosis around eyes.
Keep
Then
in mind
if
that
there is any.
you are addressing the patient as a whole, system-wise.
Yes.
What may happen following injury to the particular area.
Yes, sir.
Yes.
We'll look for the facial asymmetry. If the patient can, for the temporomandibular joint, if the patient's temporomandibular joint is intact, then
You enumerate
pupil
system wise,
size.
temporomandibular joint, system wise.
Sir, bleeding from eyes, nose or mouth or ear. If the patient has any hearing deformity, disability, or
Can water come through the nose or ear? What is that called as? Watery material is coming,
Sir, CSF rhinorrhea
or otorrhea. That indicates
or
what?
otia. Sir,
That indicates fracture in the base of the
sir,
skull.
please.
That
Yes, sir,
indicates that is
fracture
fracture in the base of
base-
the skull.
Base of skull. Yes, sir. Cribriform plate.
Then
Okay. Okay. Can we progress? Hello.
Yes.
Hello.
Hello.
Aditi, you have explored head
Yes,
injury.
sir.
Now, next part is neck and the chest.
Neck and chest. So yes, sir. So we'll look for the cervical spine injury. Any pain or tenderness. If the patient is able to move.
No, you should not do that. You do not ask the patient to move with cervical spine. That is not to be done. You in
have to
fact
stabilize it.
immobilize the spine.
Cervical spine to be kept stabilized.
Yes, don't test the cervical spine movement at this stage.
Yes.
You cannot. Rather,
Yes.
you immobilize the spine.
Yes, sir. Cervical
look for any bruise.
immobilization.
You look for any bruise, any hematoma, okay, any swelling,
Yes.
and then look for the limbs, whether the limbs has got any paresis. A cervical spinal cord injury will cause quadriplegia.
Yes, sir. Then we go to the chest examination.
Yeah, you have already mentioned that.
Yes, sir.
I think we need not go to the abdominal injury. We will
Okay.
discuss separately.
Okay.
Come to the chest now. Yes, you have examined the chest,
Chest.
and now you find patient has got some suspicion of pneumothorax, but it's not a tension pneumothorax. But it's not very clear clinically that patient has got pneumothorax or not. But there is some suspicion. There is a little lowered breath sound on the base.
So while you are doing this examination, what are the other things that you should do simultaneously in this particular patient?
So simultaneously, we should give a large bore IV lines to the patient with maintaining a target systolic blood pressure of 90. Police catheterization. Will arrange for the blood products and oxygenation of the patient. And
The patient will be in severe pain.
analgesics. Pain.
Analgesic. And as sir was saying that you are suspecting pneumothorax. So
Thoracostomy.
Then I'm saying that
it is not a tension pneumothorax.
I give a scenario that is suspicion of pneumothorax, but patient is having some distress. But clinically, you are not certain that it's pneumothorax or not because there is no gross medicinal shift.
Yes, sir.
Then how do
you confirm? How do you confirm whether there is a pneumothorax or not?
So we'll do the chest X-ray.
Yeah, chest X-ray. Chest X-ray. What?
Chest X-ray
can you diagnose all pneumothorax by doing a simple chest X-ray?
No, sir.
No. Yes. So all small pneumothorax cannot be diagnosed on chest X-ray. So what should be the next step?
Sir, CT scan.
Before CT scan, if any multi-trauma, we have a protocol called FAST. In FAST,
Yes,
you look
for
at the peritoneal cavity, and if you talk of eFAST, you also address the pleural cavity. What in ultrasound? There is an ultrasound, typical finding in ultrasound, which will suggest underlying pneumothorax. Do you know the finding? In ultrasonography, there is a typical finding which will suggest underlying pneumothorax. What is that? That is described as lung point. When you put that transducer, as the visceral pleura and the parietal pleura comes in contact during respiration,
okay, yes,
you can appreciate that movement. When there is a
lung
pneumothorax,
slide.
yes. When there is pneumothorax, this visceral pleura does not touch the parietal pleura.
Like, yes, sir. Yes, sir.
Okay, so that indicates there is an underlying pneumothorax. So you can do a EFAST, which can give you a lead to the diagnosis of pneumothorax also. Yes, CT scan.
Pneumothorax.
Do you do CT scan in all cases of chest injury, or there are some indications that yes, the other situations you should go for CT?
No, sir, not always required.
Always required.
If we are suspecting not required always. Sir, if we are suspecting lung parenchymal injury or pericardial injury or
No, the primary prerequisite is that the patient should not be in a hemodynamically unstable condition
unstable
before you do a
yes, sir.
CT scan. And then
CT
what
scan.
sir is asking, what are the indications? What are the basic things that you should look for in a chest trauma, in a patient with chest trauma?
Because these are the
Sir,
points of discussion. You see, you cannot ask for all patients, but there are some indications where you have to do, even if your clinical examination is not always 100% correct. There is 20 to 30% chance that you are missing clinically some underlying chest injury. There is some chance that you are missing some underlying chest injury based on a chest X-ray or ultrasound. This
Yes, sir.
patient has got
So
one
if-
liner. Patient has got high speed
high-speed
motor
injury.
vehicle collision.
What are the other injuries that can occur? Major injuries.
It's a thoracic great vessels injury, pericardial injury, lung parenchymal injury,
Yeah, pulmonary contusions,
pulmonary
Then,
condition.
then
Yeah.
other injuries with air leak.
Sir, diaphragm injury,
Diaphragm
esophageal.
injury is not per se just gestural injury. Diaphragm is different, but talk of some medicinal structures which can get injured.
So esophageal injury,
Before that, tracheobronchial injury.
tracheobronchial
Aortic injury.
injury.
One important blunt trauma is aortic injury. It's not very uncommon.
Yes.
So keep
Now,
in mind all these injuries. which
Aditi,
are
I'm
very
asking you a
difficult to
question here.
diagnose clinically.
Yes.
Suppose you have put in a chest tube. You said that you have put in a chest tube and you find that excessive bubbles are coming out through the chest tube throughout
sir.
the respiratory cycle, inspiration, expiration. What do you suspect?
Sir, tracheobronchial injury close to visceral pleura.
Yes,
That
tracheobronchial.
indicates
Yes, because,
major airway injury. Yes.
Yes. Major airway.
and if you find, say, gastric content coming out through the chest tube after you have put the chest tube inside,
So then diaphragmatic injury.
Yes.
diaphragmatic,
Diaphragm injury resulting in hernia.
esophageal.
Diaphragmatic
Yeah.
herniation. Okay, sir.
No, in diaphragmatic, plain and simple diaphragmatic hernia, you won't find gastric content, isn't it? But if there is a visceral injury, there is a injury somewhere in the GI tract, only then you will find the gastric content or esophageal content coming out, isn't it? Okay. Now, next is along with that, you will do. So, what are the things you look for in FAST?
So, 4 primary sites for FAST are we look that right upper quadrant, left upper quadrant, subxiphoid area, and pelvis region. We'll look for any blood collection in the intra-abdominal region, paracolic.
Okay.
Same fluid. It's not blood. It's just fluid. In ultrasound,
Good.
you can
yes,
just make some fluid collection.
Perihepatic,
Yes, sir, fluid
perisplenic, pelvis, perihepatic, perisplenic, pelvis, and
the paracolic gutters.
Paracolic.
pericardial.
Yes,
Okay.
sir.
And EFAST, you
Yes,
add the
pericardial.
pleural cavity, another piece. Okay.
Sir.
When you are reading a chest X-ray, what are the things you should look for in a chest X-ray? You have done a chest X-ray here. You said that. What are the
Yes.
things you should look for?
Sir, we'll confirm the first patient's name and
Very
then
good.
the image quality of the X-ray if it's properly cited. We'll look if it's a PA view or AP view of the chest X-ray. And
What happens in an
that's,
AP view? Inadvertently, you are taken in AP view. What will happen?
The scapula will be projected within the
No,
chest. chest
cardiac shadow will appear.
Cardium.
Yeah. Okay, next, you have to ensure that the side determination has been done properly. Next,
Side determination is that proper exposure is there. Then both the costophrenic angles, if they are visible, if the trachea is in midline,
no, go from outside inwards, like
Yes,
soft tissue.
starting the bone,
Yeah.
starting the bone in the chest.
Even before bone in a subcutaneous emphysema, that can also be evident in a chest X-ray. Okay. So
Yes, sir.
soft
Yes,
tissue,
sir.
then comes bones, then
So then the clavicle medial end that should be equidistant from the spinous process.
yeah, that is the orientation. Okay, next, soft tissue, bones, then after the ribs have been examined, then inside, go the lungs,
Sir,
next, the cardiac shadow, next,
cardiac shadow, then
still medially, the mediastinum.
sorry.
Can you
Yes.
diagnose lung contusion by looking at the chest X-ray?
Sir, suspicion.
No. You cannot diagnose lung contusion by chest X-ray.
Contusion.
Okay, that has to be ascertained by CT.
That will require fast, if fast.
No,
E-fast will give an
EFAST
idea
will not
about the
help
air
you.
or blood. Okay, air or blood.
Yeah.
So blood may collect without a underlying lung contusion or lung injury. You say blood can collect because of intercostal vessel injury. Okay, there are some limitation of chest X-ray. You see, chest X-ray is not diagnostic of all chest injuries, but a chest X-ray is to be done in majority, almost in all cases of. But again, there are some Nexus guideline saying that one you can avoid a chest X-ray, but you're not going to this. Most of the time, for a multi-trauma patient with a respiratory distress, we always do a chest X-ray. That is a part of recommendation.
Okay, sir.
And only in life-threatening injuries that third had enumerated previously, like airway obstruction, pericardial tamponade, tension, pneumothorax, you can proceed to the initial intervention without a
Yes.
chest X-ray. Okay, what are the? Can you enumerate what are the lethal 6 and deadly dozen of chest injuries?
Yes, sir. Lethal 6 are the immediate life-threatening issues we need to handle, like airway obstruction, tension pneumothorax, open pneumothorax, massive hemothorax if there is, flail chest, pericardial tamponade, and
Very
the potentially life-threatening which needs to be addressed are aortic injury, tracheobronchial injury, diaphragm rupture, esophageal injury, pulmonary contusion, and myocardial contusion.
Very good. When you we had discussed about what are the things that you should look for in the chest X-ray. As far as the ribs are concerned, as I said, that whether there is any fracture in the ribs, you should look for.
Yes.
What are the things you should look for regarding the fracture? Important things that should be in a patient with chest trauma.
Patient has got rib
Sir, if
fracture. What are the
Yes,
things
sir.
under consideration? Will
Sir,
you
if
just
the
ignore this?
patient
This is
has-
nothing.
The patient
Yeah.
first or second rib fracture signifies
Must-
there may be a thoracic vessel injury.
Yeah, you must always rule out fracture of the first and second rib because they are associated with either subclavian vessel injury, severe lung trauma, or any cardiac
Yes.
contusion. This is very important. Other chest injuries, you have to see whether how many fractures ribs have been fractured, and if they are fractured
sir.
at one point or there
Or
are
multiple.
fractures. So, what is the definition of a flail chest?
Fracture of 3 or more than 3 consecutive ribs
At
at
what?
2
1
points.
point?
At 2 or more than 2 points.
Yes.
Yeah. 3 or more consecutive ribs at 2 or more places. And
Yes,
as we had already discussed, the patients will usually present with paradoxical respiration in these cases.
Aditi, what is central
Yes, sir.
fail chest? what is central flail chest?
Sorry, sir.
Central
What
flail.
is central flail chest? Central. There is a term called central flail chest.
Central
This can
flail chest,
occur in
sir.
a patient like this,
But-
say a driver
but-
driving a car and sustains a high velocity collision.
Understand? Central chest is where? The region of sternum.
Sternum.
So you have multiple reef fractures on either side of the sternum. The segment of
Okay.
sternum now lie loose, and that segment is drawn inward during respiration. So central chest
Okay, sir.
flail chest is when there is multiple reef fracture on either side of the sternum. The sternum becomes flail. That is drawn inward and outward with respiration. That is central flail chest. What do you mean by major flail chest and minor flail chest? There is a definition again for this because the management will differ. When you call that this patient has got major flail chest,
With
what is the pathology? When you have flail chest, what is the pathology that
Yes.
will hamper his respiration?
so the broken segments of the ribs won't expand properly.
So it will rather go inward. So what is going to
Yes,
happen? What is that particular situation called as? There is ventilation perfusion mismatch.
Mismatch. Okay. Yes.
That means that particular segment of the lung is perfused but not ventilated. So if
Yes,
there is a large segment of flail chest, this will impair
Yes.
this VQ mismatch, and that will lead to hypoxia. So if the patient has got hypoxia and ABG analysis, that indicates patient has got a major flail chest interfering with the ABG. A minor flail chest patient can manage. Patient may not have
Yes, sir.
alteration of ABG. So there is no dire emergency that need to immediately intubate this patient. A major flail chest patient needs to be immediately intubated. Okay, that is the
So-
difference between major and minor flail chest.
When Sir has asked you this question, okay, finish up. How do you manage a case of flail chest? Say minor flail chest. Just
Where
enumerate.
to
what are the-
treat this patient, in the ward or in the ICU?
So,
A patient having a minor flail chest, where do you treat this patient?
if the patient is stable, then we can
Yeah.
manage it in ward.
No.
No, no, no.
Even in minor flail chest, patient should be to intensive therapy unit, because when the segment is flail, it can cause underlying lung injury. Okay,
Okay.
this can anytime, unless you monitor this patient properly, this patient may deteriorate suddenly. So this patient should be in ICU, but this patient does not require immediate intubation. That patient is
Okay, sir.
proper monitoring.
So what should be done to these patients? Number one, you should shift the
we-
patient to HDO or intensive care unit. Ensure that
Okay.
patient receives high flow oxygen, isn't it? Humidified high flow oxygen to maintain the saturation above 95%. All right. Such
Okay.
patients are
Yes, sir.
usually severe pain. So you must ensure that the pain control. What else should be done?
So we'll manage the analgesia part. Then rib-
एनाल्जेसिक हो गया उसके बाद what type of ventilation would you this high humidified oxygen you said, how do you
Positive.
administer that? Yeah,
Positive pressure ventilation.
CPAP that
CPAP.
can, if you ensure CPAP from the very beginning, that is continuous positive airway pressure ventilation, that can prevent this, what I said, an invasive ventilation like an intubation. All right. At the same time, you
Yes, sir.
should ensure that the fluid balance is properly monitored. Why?
Sir.
Very important as far as chest injury is concerned. You should not overhydrate these patients. Why?
Yes. So if we overhydrate, then if there are small clots, they will
No,
dislodge.
that is different. That is different issue. But as far as chest is concerned,
Then, sir, injured lung will accumulate the fluid.
yes, that will lead to pulmonary edema. So it will be should be properly monitored. Should not overhydrate at all. And
Overhydrate.
chest physiotherapy, and most of the time these will take care of the failed chest. Rarely is some surgical intervention required for management of the failed chest.
Okay, Aditi, in a hemothorax, you put a chest tube. How do you
Yes, sir.
decide whether this patient needs thoracotomy or not? Hemothorax patient, you put a tube, and now you are waiting, observing the patient, and you have to take a decision whether this patient will require thoracotomy or not. What are the indications of thoracotomy in a patient who has got hemothorax? Primary treatment is tube. When will you
Yes, sir.
consider patient needs a thoracotomy?
Sir,
There
in
are some
case of
criteria.
hemorrhage,
Huh?
How much?
There
The
are some
moment you-
criteria.
more than 300 ml
Very
No.
good.
or
No, before that,
or
if you put the tube,
or
if
sir,
you put the tube
yes, sir.
on first insertion,
Yes, sir.
more than 1
Yes, sir.
liter bleed is a massive hemothorax, might require thoracotomy. Second
No,
is,
Yes.
I think she said that only, huh?
she said 300. She
300
said 300, not 300, 1 liter.
No, 1 liter.
Second is called as brisk bleeding. If you have a bleeding of 100 ml every 15 minutes for next 1 hour,
Yes, sir.
that is described as brisk
Okay.
bleeding. Another term
Yes,
is
sir.
called as a continuing bleeding. Patient is bleeding a patient is bleeding 200 ml per hour for next 3 hours. These indicates the patient has got either a massive bleed,
Massive hemothorax.
has got brisk bleeding,
Yes, sir.
or patient has continuing bleeding. And this patient might require thoracotomy. Why is thoracotomy required in patient has got hemothorax? What are you going to
So to
do
evacuate,
to evacuate hematoma? Why? Why you need to evacuate the hematoma?
the
What
proper
is
lung
wrong if you keep this hematoma in?
expansion.
Hematoma is a good medium for bacterial growth. It can
Right.
cause empyema. It can cause underlying fibrosis, impairing the lung expansion. And if the patient has got a continuing bleed from intercostal vessel or any other intrathoracic vessel, unless you ligate the vessel, you are
Yes,
not
sir.
going to
Good.
salvage the patient.
Bleeding won't stop.
Yes. Okay, so these are the indications where you should consider for doing thoracotomy.
Yes, sir.
Okay, when
What is
you're
Stobin chest? Aditi, what do you mean by Stobin? There is another term called Stobin chest.
Probing chest. Hello.
stove
chest. What is that
in.
injury? STOV, Stobin
It's like-
chest. Huh?
I don't know. sir.
Stobin chest injury is one where you have multiple rib fracture at one point, and that segment of chest is drawn inward. There is indentation in the chest wall. That segment is not showing paradoxical movement. That segment
Okay.
is indented because of multiple rib fracture at one point. That is described as Stobin chest. What is sucking wound in the chest? What do you mean by sucking wound in the chest? Yes.
So open wound with
Yes. Open wound up
air
to what?
one
Open wound up to what level?
to
Up to?
parietal pleural level.
Right.
So open wound means you have complete penetrance of the chest wall up to the pleura. So what happens? Why it is called sucking wound?
So because it creates a one-way valve, and
So what happens? What is being sucked, and why this air is sucked?
During inspiration, what happens?
Sir, at chest wall pressure will be more than atmospheric pressure.
No. Inspiration, chest wall pressure is not more. Try to understand. During inspiration, intrathoracic pressure is less. Inspiration is a active process. Why does the lung expand? Because intrathoracic pressure is less. So when the intrathoracic pressure is less, there is open wound, air will be sucked in. That will impair lung expansion. Okay, sucking in means the air is sucked in during
Air is
inspiration.
sucked into the cavity, and the air from the normal tracheobronchial tree will not go in.
Try to understand. Intrathoracic pressure does not increase during inspiration. Intrathoracic pressure falls during inspiration. That you must be very clear. During inspiration, interstitial pressure is negative. During expiration, interstitial pressure is positive.
How do you manage these cases? This is open pneumothorax.
Primary management. On arrival, what do you do?
Simple things.
These are all standard descriptions, Aditi. They're all standard. On arrival, you seal the wound on 3 sides. Keep the
Occlusive
wound
dressing with
open on
3
one
sides,
side.
taped on 3 sides.
So don't
What will
allow
happen?
air to be sucked in, allow air to be pushed out from the pleural cavity. And then what is the definitive management? If you have a sucking wound in the chest, will you manage this in the ward or patient needs to go to the theater? Aditi, you're on? Aditi, you're
Hello.
on or you're off?
I think we have lost her again.
Okay, okay. She
Yeah,
again
she is
got
no longer there.
Okay, fine.
Mehul,
Nitesh, you
Mehul will
answer.
answer.
Nitesh, answer.
For the open wound, sir, will do the occlusive dressing.
No, dressing is done primarily. So these wounds needs repair in the operation theater. So this open wound has already caused pneumothorax. So this wound need to be explored. So you have to manage the other parts. You do a comprehensive assessment and find that is the only injury. This patient should be taken to the theater. You explore the wound, repair the wound, and put a chest tube. So that is the definitive management for sucking wound in the chest.
Chest wound through a different site, not through that.
Yeah. For
injured
a different site, yes.
Okay. Then
Anything
who is
else to add,
answering?
Dr. Bhattacharya? I think we have discussed. Because see, basically for any injury, the primary questions will be on ATLS, and then come to the comprehensive management of the life-threatening injuries, and then pass to the particular injuries. Unless examiner is very biased that he lacks only liver injuries, that is very rare situation. Only the liver part is discussed. You have to, your approach should be the general and then the specific liver injuries.
Sorry, sir, my connection was lost for 1 minute.
Yeah. We asked, I asked you the last question. How do you manage the sucking wound? So this wound should be explored in the operation theater. So you have to repair the wound and put a chest tube because already patient has got pneumothorax. Once you have a
Yes.
sucking in the chest, patient already has pneumothorax. This patient needed tube thoracostomy. So you have to repair the wound and put a chest tube.
Yes, sir.
Another, I think, just a passing remark. There is a small apparatus that can be used here, which is called, I think, Asserman's chest seal, where you can, that will also allow one way, allow the air to escape out, but will not allow the air to go inside.
The idea is that you should not
Okay.
allow the air to go in
Uh-huh.
because that will cause a tension pneumothorax. If the
Yes,
air
sir.
keep on going,
One final question, when we were initially simultaneously resuscitating the patient and doing some investigations like EFAST and chest X-ray and all those, we also should do an ECG. Why? Especially
So
for
we
blunt from chest. Yeah.
So ECG. So
Yeah.
for blood cardiac injury, sir.
Yeah. What will be evident in the chest ECG in blunt cardiac injury?
So arrhythmia.
Yes, tachyarrhythmias will be there. And
in contusion, it can show picture like mitral infarction.
yeah.
Okay. Yes, sir.
Achha, Aditi, if I measure failed segment, you put the patient on ventilator. How will you stabilize this failed segment? Patient on ventilator.
Yes, sir.
How the failed segment will get stabilized?
So rest.
Patient is on ventilator. He's at rest. He's in ICU.
Yes.
How the failed segment will get stabilized? The answer is, if the patient is kept on ventilator for 2 to 3 weeks, the failed segment automatically gets stabilized because during positive pressure ventilation, this failed segment pushed outward, and gradually this failed segment get stabilized. If for some reason that this patient is meriting some thoracotomy for other reason, not for flail chest. Patient has got continuing bleed, patient has got esophageal injury, major tracheobuccal injury. So if the patient requires thoracotomy for other reason, in that case, you have to fix the flail segment. How can you fix? How can you fix the flail segment? How the
Sorry.
knee fracture fixed?
Double human endotracheal tube.
Any fixation of fracture.
Operating. That technical tube is taking care of the spontaneous correction. You have explored, now you have fracture in front of you. How can you
Yes.
fix the refracture?
So splinting.
What
We'll
splinting? What splinting? You're operating. Splint is placed outside, not during operation. It's a fixation.
Wire fixation.
Okay, do a wire fixation. You can keep plates also. So you need to
Okay, sir.
fix. Routinely, you don't operate for fixing a flail segment. If you ventilate the patient for 2 to 3 weeks, this flail segment gets stabilized.
I think
And
one
if you're
final
operating for
question.
other reason, you need to fix.
One final question to her. The patient
Yes.
patient had a chest tube inserted. When do you remove this chest tube?
Sir,
Can you
when the
tell us
lung
please,
is
Luke?
properly expanded,
How do you know?
so the air column will stop moving.
You will not examine clinically before that?
So yes, sir, air and that breathing sound which has decreased earlier will.
Yes. So auscultate
can
the base of
hear-
the lung.
Yeah, breath sounds throughout the chest. The swinging should be the column swing should be less than 2 centimeters, less than 2 centimeters, and the
Yes, sir.
amount of fluid coming out through the drain should be less than 25 ml. Okay.
Yes, sir. Yes.
All
Sir.
right. And after you have done you have removed the chest, what should you do?
Repeat check chest X-ray.
To
While
be
removing
sure-
the chest tube, do you do anything
Yes.
with the wound?
Sorry, sir.
When you
For the
remove the
wound.
chest tube, how do you manage
Yes, sir.
the tube entry wound? Have you inserted a chest tube anytime?
Yes, sir. Yes, sir.
What do you place in the
what do
wound?
you place there in the around the tube something?
So purse string suture.
Yes. So while you
That
take the tube out, the person
Yes, sir.
suture should be tight, so that
Tight,
no more
yes, sir.
air goes from the
No
outside.
air leak. Yes,
And
sir.
you should tell the patient not to breathe for few seconds when you are taking the chest tube out.
Yes, sir.
Okay.
Yes, sir.
And after the chest tube has been removed, you should do always a chest X-ray to ensure that the lung has properly expanded, and you have not again. I mean, during removal also, air didn't go inside. Okay,
Yes.
Okay.
both things
That
that can also happen.
Yes,
I think
we have
yeah.
covered at least the what is being asked in the exam. We have covered that part.
exam.
So if you are
Exactly.
at least conversant with these questions, you'll be through for a ward round scenario in chest injury. I'm sure about it. Thank you, Aditi. You have answered well.
Thank you.
Okay.
Thank you,
Thank you.
sir. Thank you so much.
Thank you.